Yeah, some colleagues, very often practitioners, but also colleagues from the university, contact me on congresses and they ask me, why is there no RCT, no randomized clinical trial available for corticobasal implants? This question astonishes me because they should know what it is, a randomized clinical trial. The answer is, to what should we compare it? I mean, there must be a study group and a second group. So if we would compare osseointegrated implants to corticobasal implants and we do a randomized controlled trial, this means that one patient comes in, he goes into the osseointegration group, the next patient comes in, goes to the ossofixation group, and so on, ding ding ding, just randomly patients are assigned to their group. Now, if you know at least something about corticobasal implants, and if you know what happens in the osseointegration field, there will be, of course, a big disaster happening very soon, because many of these patients who are unlucky to end up in the osseointegration group don't want to do the treatment. Of course, they had a completely different expectation about osseointegration. They thought they get the implants, that's it, and they pay it. And then they find out, oh, suddenly they have to do bone augmentation, which takes, let's say, half a year or 8 months, and they have to put the implants in. They have a healing time, another 4 to 8 months for the healing time of the implants. They have a lot of risks, infections, loss of the graft, loss of the implants, and so on. Very, very, I mean, these risks accumulate with every surgical intervention which is done. So they don't want to do it. They rather stay with their teeth. So the osseointegration group loses a lot of patients automatically. So what can be done with these patients? Now, if they are enrolled in a study group, in a randomized controlled trial, they cannot be taken out of the trial. So a patient which is in, and the outcome will be reported. Now, if the patient doesn't want the implants or doesn't qualify for the implants, also for medical reasons, or because a patient is a smoker and he cannot get the bone augmentation due to the fact that he smoked, because the sutures will not close, etc. So the risk of losing the bone augmentation is high, more than 50% very often. And then this patient is in the study group, and it is not possible to take him out. I mean, it would be, of course, a cheat to take it out. I'm sure it is done, but this patient is in there. On the other hand, if you look at the ossofixation group, at our group, no patient does any bone augmentation, no patient has any healing time. All the patients are only happy to get rid of their teeth. We immediately put the implants and they get their bridges. So we have two completely different technologies kind of competing against each other. But on the side of the osseointegration, there are a number of disasters happening. Basically, the study group of the osseointegrated implant will never succeed. I mean, hardly any patient will reach a treatment aim. So that's why this is not done. So nobody wants an RCT in the group of osseointegration. So what is so-called the ITT principle, the intent to treat principle, must be respected, but it is usually not respected in the field of osseointegration. And if those two methods would compete against each other in one study, of course, the osseointegration group would make second, I mean, with a big distance. The next problem that such a study would have is the informed consent. Now imagine the doctor who gives the information to the patient about the treatment would tell to the patient the following. First, we do bone augmentation. This takes, let's say, 8 months. Then we put the implants and you wait another 6 months. And then we take the healing screw and so on. So you have 3, 4, 5 surgical interventions, and this all takes 1.5 years. And then finally you will get your bridges, and the survival rate is, let's say, 95% after 5 years. And if he would go for a real informed consent from the patient, then he would have to tell the patient, look, but we have to tell you now that there is also this what they call ossofixation. I don't know anything about it, but it exists. There are studies, a lot of studies are available. And I know also a lot of patients are already treated, and I have to tell you, you can get the same thing in 3 days, and you don't need bone augmentation. You have to wait simply in 3 days. It's all going to be ready. So this means that the osseointegration group would be empty. No patient would sign for this crazy procedure with the bone augmentation, healing time, and so on, with all the risks, the rough surfaces. In the end, they can also get perimplantitis, which they cannot get in the group of ossofixation. Of course, no normal patient would ever do this. So the reality is that in Germany, Austria, Switzerland, and so on, why are so many osseointegrated implants being sold to the patients? Because they are not informed properly. The patients are not informed that this crazy procedure is not necessary at all. This is the same problem, I mean, which is in the reality. The same problem would be inside the study. So the RCT would include that there are 2 study groups, and the patient of one group are going to be informed what is possible to get in the other group, or in general what is possible to get on the market. And of course, no patient would agree to be in the osseointegration group. So that's why people talk about RCT, that this is missing. And I don't think it's missing. I think it's impossible to do such a study. The whole idea would blow up in smoke in very short time. If the doctors would look realistically on the situation, if they would give a realistic outlook on these treatments, the patients would never choose osseointegrated implant, I'm sure. I mean, I see this every day in my clinics where I work. Simply patients don't want this.